was great. Let me just show you a picture of the body we made, and what we were trying to get across in this point is all the processes and diseases that are associated with insulin resistance. We'd just like to show you this.
Sure. And I know you've had a lot of experts talking through various parameters here, and we focus a lot, I think, on the heart and the adipose tissue and the liver. That's what we're drawn to talking about when we talk about insulin resistance. But we forget that insulin resistance not only impacts those obvious organs, but it also impacts female organs. It impacts our reproductive system. Polycystic ovarian syndrome is a disease that impacts 10%, or probably at this point it's more than that with obesity epidemic as it is, but the statistics usually say 10% of women have polycystic ovarian syndrome. I mean, what is that? I mean, women think it's the irregular periods and the hirsutism, the hair growth on the upper lip they don't like, the abdominal weight gain. They come to their doctor complaining of those problems, maybe acne, maybe hair loss and male pattern hair loss that's unexpected. That's what women think about. That's what they care about when they come to their doctor to get addressed for polycystic ovarian syndrome. That tends to be the focus because you want to make people feel better and have normal cycles. But what's really at the root of that disease is insulin resistance. Insulin resistance impacts sex hormone binding globulin, which impacts production of FH of LH and FSH, which impacts production of steroid hormones, which ultimately cause a woman to have challenges with ovulation, and that's what in part makes her cycles irregular. So you want to fix that. What doctors typically do is you plop the woman on an oral contraceptive. Her periods are now regular. We're done. You know what you've done? You've done nothing to correct the root cause of the problem, which is insulin resistance. So a much better way to approach that type of problem is to target the insulin resistance, and standard of care for PCOS is putting women on metformin. What's metformin? Metformin is a drug for diabetes. It's a drug that's very appropriate to use in a patient who's insulin resistant. It's standard of care for a woman with PCOS. And why does it actually ultimately fix not only her insulin resistant issues that cause abdominal weight gain and her cardiovascular and diabetes risk, but it also impacts her ability to even get pregnant. It improves her ovulation because we're reversing the problems that insulin resistance has caused. That's how you treat the disease. And unfortunately, we don't treat it aggressively enough in these patients. There's small studies even with some of the other diabetes drugs. Exenatide, for example, there's some studies looking at exenatide in women with polycystic ovarian syndrome, and that too improves women's ability to ovulate. And again, this is a drug that's not being used for a patient with diabetes. It's being used for a woman with polycystic ovarian syndrome when what we really need to address is the insulin resistant state that she's presented with. Same thing is true when women become pregnant, and in that second, third trimester of pregnancy, their body becomes insulin resistant. It's part of what we all naturally have. However, if a woman has a predisposition to this, there's diabetes in the family, she's already got a predisposition to insulin resistance, she can really run into trouble in that third trimester and then become diagnosed with gestational diabetes. And unfortunately, we spend a lot of time taking care of women when they're pregnant and they have gestational diabetes. We focus on that, and we obsessively call them every day, and we have them monitor their blood sugars. I had it. I had to inject myself with insulin 7 times a day, and you know what happens when you deliver that baby? You're off the face of the earth. Nobody cares anymore. Nobody's following you for this insulin-resistant state that you've obviously developed, that over time you now have a 50% increased risk of developing frank diabetes. We should be very aggressively monitoring those women for insulin resistance, looking at A1C, doing NMRs, trying to find other ways to assess an insulin-resistant state so that down the road we can prevent potential complications. So those are some of the key issues when we talk about insulin resistance that really impact a woman specifically. And then there's one area here, I know everyone's kind of touched on a lot of the areas, but I want to hit the brain. I don't know how much we've talked about the brain.
Oh, good.
All right. I want to talk about the brain because we forget that insulin resistance impacts the brain. Normally, when we wake up in the morning, we have this surge of dopamine. And dopamine basically sets off a cascade of events that basically regulates blood pressure, glucose, lipid metabolism throughout the course of the day. If you have insulin resistance or you have diabetes, That release of dopamine in the brain doesn't happen because of insulin resistance, because of insulin and its effect on the hypothalamus in the insulin resistant state. You don't get a dopamine surge. You wake up in the morning and it's flatline. What does that do? That actually causes a cascade of events that increases sympathetic tone, causes blood pressure to go up, causes free fatty acids to be released, increases triglycerides, causes so blood pressure, glucose, and lipid abnormalities throughout the course of the day. What's interesting is that there's actually new therapies now for diabetes that target that pathway. Completely new, unique mechanism. But what's interesting about those drugs is that they're very effective not just in the patient with diabetes, but in the patient with insulin resistance. Although, as you know, there's no drug approved for insulin resistance. They're very effective there. The one I'm talking about is the quick-release bromocriptine. I don't know if you've heard of that. It's called Cycloset. It's marketed that way. And what the drug is it's a dopamine agonist that when it's taken first thing in the morning, within 2 hours of waking up, it gives the body this dopamine surge, which resets the hypothalamic clock and allows for a resetting of all these abnormalities. So what ultimately happens, blood pressure drops, triglycerides may drop up to 30%, postprandial glucose drops, and you're basically resetting that brain clock that's been impacted by insulin resistance. And that's something that's even beyond the, the Alzheimer's and the stroke and the dementia issues that we may talk about with insulin resistance as well. But it's an area I don't hear talked about enough, and I think it's important. And we have therapies to actually target that pathway.